So, hello everyone. I'm Trevor Hassel, and it is my pleasure in my capacity as President of the Healthy Caribbean Coalition to welcome everyone to this, the first in a series of HCC-led webinars on the development of alcohol policy in the Caribbean. Today's seminar is being conducted together with the Caribbean Institute on Alcoholism and Other Drug Problems, otherwise known as CARIPAPAN. And it's been made possible with the assistance and support of several partners, including the NCD Alliance and the Department of Health in the United Kingdom. The intention of the Healthy Caribbean Coalition to conduct a series of webinars over the next several months in support of a wider program of action which includes strengthening Caribbean civil society alcohol advocacy capacity through known as CARIPAPAN, which is the Caribbean Alcohol and Policy Action Network. Today we are delighted to have Dr. Rehm as our featured presenter, and we look forward to a highly informative and lively discussion on the topic of the need for alcohol policy in the Caribbean. I now would like to invite Dr. Cariad to introduce Dr. Rehm.
Thank you, Sir Trevor. On behalf of CARIAD, I wish to join Sir Trevor in welcoming you to this webinar. A little about CARIAD to start with. We represent 40 years of alcohol and drug abuse prevention in the Caribbean. We are probably known best for our annual 2-week training program, which for the last 4 decades has been the main vehicle for addiction education in the Caribbean. In fact, quite a few of you might be graduates of CARIAD. CARIAD has long been a proponent of alcohol control in the region. In fact, Professor Michael Bobron, our founder, made the first call in the Trinidad and Tobago Parliament for the introduction of breathalyzers in the 1960s. And some of you may know that it took over 40 years for the Breathalyzer Act to be implemented since this call. CARIAD remains at the forefront of alcohol and drug abuse and policy and has recently joined hands with the HCC to this end. CARIAD also hosts annual 3-day specialized workshops for graduates of the basic program and other select groups. These aim to increase knowledge and or skills in a specialized area of alcohol and drug use prevention. In June of this year, our specialized workshop served as a professional consultation on the draft national alcohol policy of Trinidad and Tobago. Our main facilitator at this workshop was Professor Jürgen Rehm, a scientist who has distinguished himself as a true international expert in alcohol policy and harm reduction. Dr. Rehm wears many hats. Based at the Center for Addiction and Mental Health in Toronto, Canada, he is the director of the Social and Epidemiological Research Department Health Research Group. In addition, he is the chair of addiction policy at the Dalla Lana School of Public Health and professor in the Department of Psychiatry at the University of Toronto. Professor Rehm has received countless grants and been involved in numerous research projects spanning alcohol and drug use issues and other aspects of mental health throughout North America and Europe. He has participated in governmental and international commissions and has over 500 articles in peer-reviewed journals, book chapters, monographs, and reports. One wonders, therefore, where he gets the time to head the PAHO WHO Collaborating Center for Mental Health and Addiction, a position which has equipped him with tons of experience in alcohol policy globally. CARIAD was very pleased to have had Professor Rehm lead out an successful workshop in June. And today, welcome Professor Jürgen Rehm to this first CARIPAPAN webinar. He will be delivering a presentation, The Need for Alcohol Policy in the Caribbean, following which you will have opportunity for questions and comments. I welcome and introduce you to Professor Jürgen Rehm.
Thanks a lot for those very kind words, Sandra. I will try to walk you through the need for alcohol policy specifically for the Caribbean. Basically, the need for alcohol policy has been again underlined at the last World Health Assembly. At the last World Health Assembly, there was the global status report in May of this year. There was a press release where WHO said that alcohol kills one person globally every 10 seconds. That means that overall, alcohol kills around 3.3 million worldwide each year, and it's one of the biggest risk factors, not only for mortality, but also for burden of disease, for morbidity, for disability. How do we know those facts? Basically, they stem from a comparative risk assessment where we try to find the nexus between alcohol consumption and morbidity and mortality. For alcohol consumption, not only measure the volume, the overall volume of alcohol consumed, but also the patterns of drinking. And the patterns of drinking mean that there is a difference. If one drinks one glass, a small glass of wine, 0.1 liters every day in the evening, or a bottle of wine every Friday. The volume of these consumptions are the same, but the health consequences are much more detrimental if you do binge drinking, i.e. if you drink a bottle of wine in one setting. This, of course, is not only true for this one example, it is always true that very heavy drinking occasions for your health. We measure the impact of alcohol not only on incidence, i.e. on the etiology for creating diseases. Alcohol causes diseases, but also if you have a disease and you continue to drink alcohol, we measure separately the impact of alcohol on the mortality. So, if we say that we combine alcohol consumption with diseases, what is Caribbean drinking like? Is it in line with global development? Overall, and I had to just change it backwards, you see that the Caribbean is drinking 5-6 liters, which is more or less the global average. There are, of course, regions which drink way more than the Caribbean. For example, the Eastern European regions. There are also regions where much less alcohol is consumed, and that would be the belt from Northern Africa over into Asia, and this is mainly due to Muslimic religion. If you look into alcohol and compare the Caribbean countries to the Americas, you see that they are all over in the American map. Grenada is one of the countries which is one of the highest consuming countries. St. Lucia and Trinidad, Dominica, which would be the world average. But there are also Honduras and Antigua, which have less consumption. But overall, most countries are smack there where overall the world average is. It is not only recorded consumption which we measure, but also unrecorded consumption. This is all alcohol which is not being taxed and which is not being registered officially. This is one of the problems for the Caribbean, because we know there are artisanal spirits on sugarcane basis from home production or illegal production or from non-recorded production, which are produced in almost all of the Caribbean countries. Alcohol, i.e. the consumption of medicinal alcohol, for example, has been reported by several governments. So we know there is unrecorded consumption. However, there had been no studies so far to actually look into this problem in a more quantitative basis. And from all accounts, we believe that currently the unrecorded consumption in the Caribbean is underestimated. There's also some numbers which are higher than the overall numbers in the world, and these are numbers which have to do with the patterns of drinking. If we look into heavy episodic drinking in the total population, or in 15 years, adolescents, 15 to 19 years, we see that the whole region of the Americas, here include the Caribbeans, have much higher rates of happy episodic drinking than the rest of the world, except for Europe. That means that overall, in the Caribbean, while the overall drinking is about the average, we do have a problem of binge drinking and of heavy drinking occasions at certain events, for example, Carnival. If we look into the burden of alcohol, we see that alcohol is related to a lot of different diseases. Let us start with cancer. Once you ingest alcohol, all of the regions where the alcohol touches, it is the pharyngeal region, the esophagus, the larynx, the stomach is highly probable but has not been included in our calculations because it is not a grade 1 evidence for it. The colorectal cancer, liver cancer, and pancreatic cancer. In addition to this pathway of alcohol down the body, there is also the female breast cancer, which can be caused by alcohol. Overall, alcohol is a known carcinogen to humans, and this has been done by IARC, the International Agency for Research on Cancer, and it's not disputed by anybody, not even the alcohol industry. Alcohol is a very potent carcinogen, pathway down the body of the ingestion of alcohol plus the female breast are affected. The neuropsychiatric diseases which are related to alcohol are the alcohol use disorders. Very clearly, those disorders would not even exist without alcohol, and primary epilepsy. Diabetes is one of those disease categories, together with ischemic heart disease and ischemic stroke, where we do have protective effects of alcohol, but only if alcohol is consumed regularly and in small quantities. Most of the cardiovascular diseases, hypertensive diseases, hemorrhagic stroke, atrial fibrillation, and flutter are all negatively affected by alcohol, i.e. the more you drink, the higher the risk for those diseases. Most of those risk curves are exponential. Drink between 1 and 2 drinks, the difference is smaller. If you increase your drinking to between 2 and 3 or 10 and 11, it will be much larger. So the same amount of addition of drinking leads to higher chances of different diseases. There's also the well-known gastrointestinal diseases, liver cirrhosis and pancreatitis. Alcohol has also been known to increase the risk for infectious diseases, tuberculosis. It affects the course of HIV and AIDS, and it affects pneumonia. Finally, the existence of FAS, the fetal alcohol syndrome, reminds us that it's not only the drinkers who are affected by alcohol, but also others, in the case from mothers drinking. It is not only disease categories, but also almost all kinds of injuries which are linked to alcohol. One of the most important things, and this is especially important for those of you who work on non-communicable diseases, is that alcohol is a causal factor for a number of non-communicable diseases. From the ones who are part of the NCD framework of WHO, alcohol affects heart disease and stroke, diabetes, and cancer. It also affects, as I already said, pancreatitis and liver cirrhosis, which are clearly non-communicable diseases, but not part of the NCD framework. The typical picture on what alcohol affects in the Americas. What is very important here in number of deaths is interpersonal violence. Injury as a whole is more than 1/3 of all of the alcohol-related deaths are via injury. I've seen that you have some specific event on injury and violence for the Americas as part of your future agenda, and this is absolutely necessary. Interpersonal violence and injury in the Americas, and the Caribbean is no exception here. I could present you data from Trinidad or from the Caribbean as a whole, which look very similar, have been one of the most important disease outcomes affected by alcohol. It is not only interpersonal violence as intentional injury, but also suicide. And from the injury side, it's basically all of the injuries: drowning, fires, falls, poisonings, and motor vehicle injuries are all affected by alcohol. Very clearly, acute alcohol, and there again, binge drinking plays a role, does play a huge role. Overall, the higher your blood alcohol level, the higher your risk of injury, and again, the relationship is exponential. Liver cirrhosis is for alcohol a little bit what lung cancer is for tobacco. However, about 8, and not 80, but liver cirrhosis would be due to alcohol. And even those who are not due to alcohol, in the beginning, if you, for example, get a liver cirrhosis from hepatitis, if you continue to drink alcohol, you'll increase the risk of liver cirrhosis death. So overall, it is the highest link, except for alcohol use disorders, which would disappear to 100% if alcohol disappeared. Most of the disease categories related to alcohol have lower attributable fractions. That means that for breast cancer, about 5-6% in the Caribbean would be caused by alcohol. For other diseases, it may be 10-15%, and most of those overall numbers would be below 2. One of the reasons why overall the impact of alcohol is hardly recognized. If your neighbor dies, most people would ask, was he a smoker if he died from lung cancer? If you die from breast cancer, nobody would ask, was she a drinker? So the problem from the perception of alcohol is that alcohol is underestimated because it affects so many disease categories, and a lot of them it affects to 10%, 20%, 25%. The alcohol-attributable deaths in 2012, and you see overall that for all of the Americas, you have a pattern where most of the diseases, the highest proportion is affected by alcohol in the late teens, 15 to 19, and early adulthood, up to age 40. In age 80, much, much lower proportions of alcohol. That leads to something that in the average age of a tobacco-related death is over 70, versus the average age of an alcohol-related death in the Caribbean is around 40. So alcohol kills quite early. The deaths alone are not the best indicator. You should look more for indicators like years of life lost due to premature mortality. This is the overall alcohol-attributable harm for the Caribbean in comparison. You see that there are differences within the Caribbean, Caribbean numbers. Jamaica has slightly lower numbers, Canada has higher numbers. Overall, deaths and deaths are slightly higher for the global picture than for the Caribbean. So can we conclude now that there's no need to worry? Unfortunately not. Overall, in the Caribbean, every 20th year of life lost to premature mortality or disability is due to alcohol. This is quite high. And overall, burden seems to have increased over time, and if no policy is done, we would expect a further increase of alcohol-attributable deaths in the Caribbean. You can see it, for example, that the alcohol-attributable cancers, which reflect drinking patterns about 15, 20 years ago, the burden is also underestimated. As I said, when we do our formulas, we usually put in too low numbers for unrecorded and thus underestimate alcohol-attributable burden in the Caribbean. Also, the consumption of young people and binge drinking overall prevails. That means that even though the proportion of young people dies according to because of alcohol-related deaths is larger, the absolute numbers are of course small because not a lot of people die in between 20 and 30. There may be 50 to 20% of the males dying from alcohol, but overall not that many people die between 20 and 30. Much more than the proportion of alcohol is less. We expect, because of the pattern of drinking of Caribbean youth, that there will be an increase of alcohol-related death once these cohorts become older. So overall, we would expect a lot of future disability, a lot of future death and cost, if there is no policy to stop the increase of that. So we need alcohol policy. What would be the situation of policy in the Americas at all? You have no country in the Americas with a comprehensive policy to serve as a model. We do have some countries which are good single best practices with regard to different policy action. Reducing hours and days of sale, quite exemplary handled in Brazil, Peru, Colombia, US, and Canada. We see the different policy measures in the countries who have been doing quite a lot in those areas. Overall, there's not a lot of Caribbean who can claim that they have any best practices with regard to alcohol policy. Again, there's a huge need for alcohol policy in this region. There are, however, developments for change. In the regional network for the Americas, which had the representation of about 30 countries in 2012 and in the meeting 2014, there was Caribbean countries who were present. And the Caribbean region, the Healthy Caribbean Coalition was also enabling this webinar, but also the CARIPAPAN was a co-inviter, and the Caribbean Alcohol Policy and Action Network are striving to increase policy. If we look into those policies, so far I've only talked about health burden, but we do not want to underestimate that alcohol also has a huge social burden, economic burden. There are problems for the individual, there are problems of the family, with work and with society as a whole. On each of those levels, health, social. In fact, if we look into the costs of society, in many countries where such studies have been made, the costs of social burden were higher than the costs of health burden. So health is only one reason why alcohol policy should be done. And again, it is very essential that alcohol policy should not only be regarded for the drinker, but also to protect the others around the drinker. There are a lot of people who are killed by drunk drivers. There are people who get FAS because of mothers drinking. If we compare the risk for alcohol-related death, just to give you one example, and compare it to other involuntary risks, i.e. the risk from WHO has fixed a limit that involuntary risks from soil, from the water, or from the air should be lower than 1 in 1 million lifetime. The risk of harm to others in this region from drunk drivers, from others drinking alcohol, on people not consuming alcohol, on people not consuming alcohol in the situation is actually way, way larger. We would never accept such a high risk for others for any other risk factor. It is higher also than secondhand smoking. So the conclusion is that the burden of alcohol consumption in the Caribbean is slightly below the average, but still very high. It is the health burden. The harm is not restricted to health or to the social burden. In terms of costs, is about half of the overall cost. And we should remember that all of alcohol-attributable harm is in principle avoidable with better policies. What would be those policies? Prevention is important, and the WHO best buys for cost-effective prevention are the following: taxation, reduction of availability, and a marketing ban. But we should also not forget interventions for heavy drinking, brief interventions, including formal treatment. If we look into what science tells us, it is very clear that increased alcohol availability leads to increased consumption and leads to public health safety problems. This is true, has been studied so far. The density of outlets for alcohol does play a role into consumption. With taxes, we have more than 100 studies in different countries. If alcohol taxes are increased and the prices of alcoholic beverages will increase as well, then there will be decreased youth and other alcohol consumption. It's not only youth, but it's all other age groups, and it decreased public health and safety problems. This is very important, and it even applies to people who would qualify for alcohol use disorders. They're a little less elastic in reacting to price, but overall, most alcohol taxation increases led to a reduction of drinking even for people with alcohol use disorders. There's also very important that we do not have the laws like drink driving laws, like retail licensing laws. We also need good enforcement of those laws. There should be, if we increase enforcement, we decrease binge and underage drinking, especially for the retail licensing. And if we decrease binge and underage drinking, we decrease public health safety problems. Finally, the marketing. There is a lot of good evidence that marketing leads to increased intentions to drink. Our youth has seen thousands of different ads, different advertisements, and not only classical, but also by sponsoring marketing events. We have to overall decrease marketing exposure to our youth, and the more we decrease it, of course, ideally to zero, the less intention to drink and later initiation and less drinking overall. The final thing which I would like to say is the health service response in a public health perspective. This is not only an ethical problem. We have shown that if we increase treatment of alcohol use disorders and if we decrease binge drinking by brief intervals in specialized care, we also reduce the overall harm from alcohol. So overall, we have good ways, cost-effective ways, proven effective interventions, how to shape alcohol policy. It is up to us at the country level and in coalition of different countries combining their efforts to actually implement alcohol policies and reduce drinking levels and thus reduce alcohol-related harm. Thanks a lot for your attention.
Thank you, Dr. Rehm, for a very informative and comprehensive presentation. Illustrates the urgency with which we need alcohol control in the Caribbean. At this time, I would like to invite our participants to share comments and or questions. Today the meeting is in listen-only mode, so you will be speaking with your fingers. Please type your questions or comments in the chat. So the floor is now open for questions and or comments. All right, I see that we are a little slow in starting. So, Professor Rehm, I would like to ask a question to begin. We have been looking at the pattern of use in the Caribbean, and one of the most striking things is the pattern of use among females, an increase in consumption generally, and definitely an increase in binge drinking. Can you share with us whether this is a trend that has been observed elsewhere? And if so, whether any work has been done in terms of gendered interventions in alcohol control?
Thanks a lot for this question. Indeed, we do have in every country of the world still more men drinking alcohol at higher volumes than women, but unfortunately, a lot of the action, a lot of the trends is pointing towards more females becoming drinkers and becoming binge drinkers. Probably is the worst right now in UK. In the United Kingdom, especially in Scotland and England, there have been studies that females by now in certain age groups drink about as much as males. There had been some response to that. There is an attempt not to target females with advertisement. Unfortunately, this attempt has been on a voluntary basis, so some of this specific stuff targeted towards females, just wine, for example, which is called drinks, which feature different mixed drinks of fruit juices with rum, ready-mixed coolers. Those things have been targeted, A, for not doing advertisement, which has not been very successful, but in some countries, they also have been targeted for special taxes. Several European countries have actually increased specific taxes for drinks which are the most attractive for adolescents and females, and those would be mixed drinks and coolers. There's other things which currently, first of all, we have to make it way more less stigmatizing to admit to problems. It seems that stigmatization is a specific problem for females. They are even more stigmatized than the male alcohol drinker, and this leads to less help seeking, less intervention. Some of those campaigns have been ongoing in the last year. We do not have the results if they were really effective. Finally, we are looking towards specific approaches with regard to individualized prevention efforts, where some of the specific programs have females. All of this is a relatively recent development, and some of the different measures which have been taken have not yet been evaluated. I'm just telling you what has been going on.
Thank you very much for that response. Just a few comments that have been coming up in the chat. Dave Alexander from Grenada informs us that Grenada has drafted a national policy on alcohol, and they are now conducting public consultations. I see also a request for copies of the presentation. We will be dealing with this through the CARIPAPAN website, so you can keep checking the platform for that. I have here a question from Alafia Samuel from Barbados. How do you of the region that alcohol is an integral part of the economy, and they are not willing to compromise the economic and employment aspects of our alcohol production? I would read that question again. How do we respond to the governments of the region that alcohol is an integral part of the economy and that they are not willing to compromise the economic and employment aspects of our alcohol production. Professor Rehm?
Yes. Basically, just to reassure people, we will run out of time, but I will receive all of the questions in writing and I will respond to all of them. Of course, the presentation is public and can be shared with everybody. With regard to alcohol being an integral, good economic studies, unfortunately not from your region, but from Europe, but actually in Europe, I think the argument is the same, and has been made the same, that alcohol industry is a very important part of economy, and people fear that overall with the alcohol policy, we would have a less well-functioning economy. What we know about those alcohol-attributable costs, however, is that alcohol costs overall are actually by far outweighing the gains, the benefits in all of the countries. Overall, a lot of the dollars will go into different ways to cope with alcohol-related harm, and these dollars can be freed up to actually help the economy. The problem with that is that alcohol, as I said before, has costs in so many different areas. It has costs in the health sector. There are costs to the social sector. There are costs for policemen. So again, we have a lot of different costs, whereas most of the benefits, the financial benefits, just come at one ministry, the finance ministry. That creates the impression that those finances are way more important than the cost, because the cost. However, if somebody does an economic analysis and adds up all of the costs, they by far outweigh the benefits, and there had been clear signs that none of the countries who had been reducing alcohol and alcohol-related harms actually had problems with this. For example, in Italy, the alcohol consumption went down from 30 liters per capita per year to about 6 liters. They went down by 80% in Italy. There was no real consequences for the economy. So you can be assured that overall, if alcohol policy is done, there will not be negative consequences for the economy, because a lot can be spent. And of course, I can bring data for the European study.
Thank you, Dr. Rehm. And Anik Akali, that should also answer your question. How do we approach governments to change policies when alcohol production is a part of some countries' income? We simply have to show them that the cost of alcohol-related harm far exceed the gains that they stand to make from alcohol production. We have a question also from Francisco Sierra. Is there some data on the relation between socioeconomic status or educational attainment and prevalence of alcohol consumption in adolescents? So Francisco is looking for data on the relationship between socioeconomic and prevalence of alcohol consumption in adolescents. Dr. Rehm?
There are data on this, and overall, the alcohol consumption is a U-shape. Alcohol consumption is a U-shape not only for adolescents but also for adults. That means that lower and higher socioeconomic status have higher rates of drinking, and the middle socioeconomic status have the lowest rates of drinking. In terms of problems, running into problems because of alcohol consumption, both for adolescents and for adults, even though the highest socioeconomic status drinks quite well, i.e. they run into much less problems than the lower socioeconomic status. This is true for adolescents with problems which are mainly in the area of schooling, of school graduation problems, etc., but also for adults in the area of deaths. In the lower socioeconomic status, later on, the same kind of alcohol consumption leads to much higher death rates and much higher hospitalization rates than in the higher socioeconomic classes.
Thank you very much. This question, which also comes from Anik Anthony, I will throw out to any participants from Barbados or anyone who has done work. Is there data in Barbados as to the proportion of MBA secondary to alcohol use? So if there's anyone participating who can respond to that question, I invite you to do so through your chat, and I will repeat the answer as soon as I receive it. In the meantime, I will move on to the next question, and this is from Rohan Maraj from the HCC. And Rohan says, thank you very much for a great presentation. Given the difficulty with creating legislation and the fact that we have 14 independent countries, would you consider larger strategies, or should we approach one strategy at a time? Dr. Rehm?
This is a hard question. I would overall say that this helps to convince governments if neighboring countries have already acted on something and can show successes. The easiest way to show success in alcohol policies are laws which have immediate consequences. That would be drinking driving laws. And if we can show that certain actions have consequences in the next year, and if we can show that some of your countries in the Caribbean have actually lowered their injury rates, have lowered their domestic violence rates through such measures, that will be a good argument for other countries to join in. It should clearly be the goal of everything to come up with comprehensive alcohol policies that actually benchmark different areas. If there would be if there is a country who would be basically having the most comprehensive policy with all of those areas covered, it could be the benchmark for all of them. However, this is not likely. So what is likely the case is that some governments are willing to act on specific things. For example, to deal with problems of violence during Carnival. And those opportunities are usually national, and they should be grasped, and then the success should be reported to the other countries. So overall, before too long, we could really come up with a concerted action between the 14 countries. But that were opportunistic action can be only done on the national level, and those opportunities may be different for different countries.
Thank you. And we continue with the questions from Joanna Joseph in St. Lucia. The main concern is the response of the population to whom alcohol use is almost endemic, being so closely embedded in culture. Any suggestions for dealing with this? Dr. M?
Yeah, well, overall, it is true that alcohol is embedded in culture. It does not mean that enough. Let me again give you one example which is outside of your region, but I think it's a very important example. Italy. Italy was drinking about, well, it was part of the top 5 countries in alcohol consumption. It had liver cirrhosis rates which were triple to quadruple the liver cirrhosis rates of the UK at that time. It had a lot of alcohol-related problems. It had a lot of crashes on the highway related to alcohol, but it had also a high rate of chronic diseases. Everybody said that it is completely impossible to change alcohol consumption. That is where wine drinking started, with the Romans. There's a history of more than 3,000 years of alcohol consumption, dating back before the Romans, and there's good evidence that there had been part of the culture in Italy in every single regime, at least since about 200 before Christ. So this is an embedment into culture which cannot be taught, so to speak. Yet, with other and different initiatives stemming from the people themselves, they were first. They changed behaviors. They asked the state to do something before the state of Italy reacted to it. It was a continuous decrease over the past 35 years. Every single year, alcohol consumption was decreased. And now Italy drinks less alcohol than Grenada. And that is from a situation when 30 years ago, it drank about 5 times as much as Grenada. Not 50% more, but 5 times as much. If countries like Italy, where culture is so much linked to alcohol, can make this happen, in the Caribbean, it should be there as well. And overall, I do not see that a lot of the festivities are necessarily completely delinkable from alcohol. A lot of the activities of alcohol, and I think it is just a matter of trying.
Thank you, Dr. Rehm. That in itself is a topic that requires discussion in another forum, and I remind persons that we will continue to have our regular webinars. I think we have time for just one more question, and I also want to remind that the questions that have been posted in the chat that we are unable to answer now will be answered on the CARIPAPAN platform. So the last question, Ariella Rajhani from the United States says, thank you for the excellent informative webinar. Given the sensitivities around conflict of interest, how might you propose a way forward for engaging the private sector in discussions on alcohol control policies? Dr. Rehm.
That is tricky question, and there are different ways how to handle that. Very clearly, there are countries and traditions which would include a lot of the private sector except for the alcohol-producing industry. However, when we did alcohol policy in Canada, the government said that the industry, the alcohol industry, had to be at the table. So what we came up with was a number of test cases and principles where everything had to adhere to. Of course, industry wanted to have self-regulation for advertisement. So we said, okay, but the panel to judge on whether you violate the rules should not be part of industry self-regulation. You say what you want to do, but the people judging on those regulations should be a panel which has a majority of non-industry people. That worked. Overall, I believe there's a lot of interest in the private sector for alcohol policy, but it's very hard to basically deal with the alcohol industry because of, especially overall, tells us that in something like the Caribbean, and I made those calculations specifically for today, about 10% are consuming more than 50% of all of the alcohol. That means that those who drink the most, those top 10%, if they would be away, because they also have the most problems, they have a much higher risk for liver cirrhosis, because, etc. All of the disease outcomes are in exponential function. So basically, 50% of the profit of the alcohol industry will fall away if those who are alcohol dependent or who have the most drinking would no longer consume. And that is something which is a real problem, because no matter what people say, we are completely against heavy drinking, etc. But on the other hand, if 50% of your profit is from that, that hinders some of the true collaborations with including industry. So basically, my advice would be include all of the private sector, exclude alcohol industry. If alcohol industry has to be included for whatever reason, come up with very strict criteria of measures of debate which actually test the willingness of alcohol industry to do meaningful measures and not only responsibility campaigns.
In a more stimulating session, it is clear that we have a lot of work to do, and we look forward to continued collaboration. At this time, I hand over to Sir Trevor, who will take us through the final moments. Sir Trevor?
Your line is now unmuted.
So thanks very much, Sandra. And first of all, I'd like, on my own behalf, and that of the Board of Directors of the Healthy Caribbean Coalition, to thank Dr. Rehm for being our featured and specially invited guest presenter at the first webinar. I think we would all agree that Dr. Rehm did an outstanding job and has really set a very high standard for those to follow. I'd certainly also wish to thank you, Sandra, Dr. Reed, for the many roles that you've played in contributing to the successful outcome of this webinar. Of course, the webinar would not have been a success in the absence of an audience, and again, I am very struck by the significant number of questions and discussion points that arose. I also want to thank Maisha, Maisha Hutton, that is, the Executive Director of the Healthy Caribbean Coalition, who has been responsible for the overall arrangements for the webinar. And a significant and important role has also been played by Ian Pitts, who is the IT manager and has been responsible for the technical arrangements. Now, we at the HCC have been very encouraged by the numbers of persons who have registered to take part in the webinar, and I certainly would like to extend an invitation to everyone at HCC, but also to join our electronic platform, which you've heard about, referred to, CARIPAPAN. CARIPAPAN connects the Caribbean civil society organizations working in the field of alcohol advocacy and prevention. Our next webinar will be held on the 11th of November 2014, and on that occasion our featured presenter will be Dr. Rohan Maharaj. Rohan is the Healthy Caribbean Coalition's technical advisor on alcohol policy, and he will speak on the topic gaps in current regional alcohol policy and the desire for change, opportunities for civil society organizations. I might mention that Rohan is a senior lecturer at the University of the West Indies in St. Augustine, well-received presentation at a CARICOM Health Ministers Caucus on the need and urgency for a regional alcohol policy in the Caribbean. Lastly, I'd like to take this opportunity to invite everyone to attend HCC CARIAD and CARFA-sponsored meeting titled Alcohol and NCDs, a Focus on Violence and Injuries. This meeting will be held as a satellite meeting during the 60th annual CARFA, and CARFA stands for Caribbean Public Health Agency, a CARFA Health Research Conference to be held in Grenada the 23rd to the 25th of April in 2014. I've already had a sneak preview of the draft program, and it looks as if it's going to be a very exciting meeting. And finally, I just wish to suggest that to keep updated with activities of the Healthy Caribbean Coalition, you can follow us on Twitter at Healthy Caribbean, at Health Caribbean, or visit our at healthycaribbean.org. And so finally, it is simply left for me to say once again thanks to everyone, and we look forward to another webinar on the 11th of November. Thank you very much to everyone.